ஆமாம்.
Dr. Soumya, you can start the session.
Soumya? Yeah.
Yes, ma'am.
Everybody
Shall we start?
Everybody's
Yeah,
joined?
all the
Okay.
panelists are here.
Okay, I'll just say hello and I'll tell Minnie to say hello, then take it over. Okay.
Sure.
Good evening, everyone. Welcome to this case discussion meeting of Pediatric Neurology Subsection. Minnie will say hi, then we'll hand over to Soumya for the cases.
Good
Minnie?
evening. Good evening. Please carry on. Carry on, Soumya.
Yeah, thank you, madam. Thank you, Shefali madam and Mini madam. So today we will have a very two interesting cases of neuroimmunology and one from Yashoda Hospital, Zytex City, Hyderabad, and other from PJMR, Chandigarh. So we have two expert panels also. Dr. Vrajesh Rudani sir is a senior pediatric neurologist from Hinduja Hospital, and he doesn't require any introduction as well. And the special is an expert in neuroimmunology. And the second external expert is Dr. Vishal Sondhi, is a professor of pediatrics from AFMC Pune. And he has also a special interest in neuroimmunology. As the first presenter is Dr. Jayashree Tamburne. She is a registrar from the Yashoda Hospitals, High-Tech City. And it's moderated by the Dr. Satyesh Chowdhury, and he is a consultant in the same hospital. So the first case will be the twisting tail of demyelination. And the second case will be presented by Dr. Shubham Raj. He is a DM resident from PGI, Chandigarh, and will be moderated by Dr. Priyanka Madan, who is Assistant Professor of Pediatric Neurology. So we will have the case discussion, which will be around 18 minutes, and 10 minutes we will have for discussion. So over to you, Dr. Jayashree.
Good evening, ma'am. Should I start sharing the slides?
Yes, please.
Good evening, everyone. Today I'm narrating a case of narrating a twisting tale of demyelination. Myself, Dr. Jayashree Tamburne. Today's moderator is Dr. Satyesh sir. It is a 5-year diagnostic and treatment journey of a. Should I go on, ma'am?
Yes.
Yeah, I'm audible. I'm audible.
Yeah. Please continue.
She is a 12-year-old girl child born to non-consanguineous marriage with normal birth history and developmental age appropriate. So the onset of symptoms started at the age of 7 years. She has fever for 1 day with status epilepticus, left focal to bilateral generalized with transient left-sided weakness lasting for 3 hours. On examinations, she had encephalopathy with observed left-sided observed power of partial anti-gravity movement and hypotonia. So on the basis of clinical history, so differentials thought were infective, viral and atypical organisms, inflammatory or demyelination, vascular causes, and post-ictal TOTS paresis. She was evaluated elsewhere, where blood investigations revealed raised WBC counts, and CSF cell count was 6, with a normal protein count. So her MRI brain with MR angiogram was reported as not showing any significant abnormality. Thinking of demyelination, they have sent the serum MOG levels, which was treated elsewhere with the IVIG of one dose and anti-epileptic, which for which she was responded well. Uh, this is the MRI that was reported as previously reported as normal, but she come for second review to our OPD, which suggestive of unilateral right-sided cortical flare hyperintensities with restricted diffusion at the lesion site, which predicts towards the flames. So this is the MRI, which suggestive of left cortical edema, left-sided edema. 2 months later, she presented. She was having encephalopathy uh, with MRI suggestive of cortical edema, uh, and MOG antibody was positive. In our OPD, she presented with fever-triggered right focal seizures with impaired consciousness, with post-ictal transient weakness associated with prolonged encephalopathy for 4 hours. So she was investigated with suggestive of WBCs 25,000 and CRP was normal. Her MRI brain her MRI brain revealed subtle hyperintensities in and restricted diffusion in the left hippocampus, and thickened gyri over the left posterior temporal lobe. On 22nd January, with the repeat MRI was done, which suggestive of bilateral confluent hyperintense lesions over basal ganglia and gray matter with the temporal lobe, with the long segment of spinal cord involvement. So the she has no any bowel bladder involvement. Normal sensory examination. Her informal visual testing was normal, but her VPs were absent bilaterally. Thinking of asymptomatic bilateral optic neuritis, she was treated with the IV steroids during the acute phase and monthly IVIG for 6 months with low dose of oral steroid, which were tapered over 1 year. So she was followed up for next 3 years. There were no relapses, but serum MOG levels were as follows. These were done from the same lab. So in the June 2024, she has moderately positive MOG. So she was treated with immunomodulators. 3 years later, in March 25, she presented with fall during play, followed by left-sided deviation of eyes and 3 episodes of multifocal seizures in clusters, predominantly involving left upper and lower limb. Provisional diagnosis, clinical thoughts were recurrence of MOGAD versus remote symptomatic epilepsy. Her MRI brain suggestive of T2 hyperintensities with facilitated diffusion in the left mesial temporal lobe with the mild volume loss. Her serum MOG levels were mildly positive and she was treated with IV methylprednisolone pulse doses and anti-epileptic, for which she responded well to the treatment. 1 month later, in April 2025, she presented with the right eye pain and sudden loss of vision. Her right eye showed only light perception and left eye was normal. VP right eye was no response. Left eye P100 was normal. And she was treated with IV methylprednisolone and first dose of rituximab. On follow-up, her vision was slightly improved. She can visualize at 3 to 4 feet of distance, and visual acuity over the right was 6/9 and left was 6/6, and treated with second dose of rituximab. So in the next 6 months duration, she had 2 to 3 events of PNES, which includes pelvic thrust movement, some random limb movements, and second event suggestive of right hand rhythmic movement with eyes closed, for which she treated symptomatically. After 7 months, in November 2025, her left she presented with the left eye vision loss, with the finger counting at left 1 feet, with the tremors and rapid breathing, with grade 2 RAPD in the left eye. So, serum MOG positive left optic neuritis was proposed as the diagnosis, and MRI was suggestive of left retrobulbar optic neuritis. She was treated with the IV methylprednisolone for 5 days, for which her symptoms were not improving. So, plasmapheresis 5 cycles were done, and started on MMF and steroid and tapering dose subsequently, and she was given monthly doses of IVIG for 6 months. In November 2025, these are the MRI. First MRI suggestive of some hyperintensities in the posterior retrobulbar optic, posterior two-third of optic nerve. And in the second MRI, there are the MRI suggestive of left temporal hyperintensities, which suggests of mesial temporal lobe sclerosis, persistent mesial temporal lobe sclerosis. Presently, the child is her eye movements were full. Her visual acuity were on right and left both 20/20. Tone was normal neurological examination. So at glance, the disease course is as follows. From in November 2020, she presented as first seizure with the flames pattern cortical MRI changes. In January 2021, she has a relapse with MOG antibody positive encephalitis with bilateral optic neuritis. In March 2025, she has recurrent focal seizures, left major temporal lobe sclerosis. In April to November 2025, she has sequential right followed by left optic neuritis. Her serial MOG antibody titers in January 21, it is positive, for which she was treated. May 2023, serum MOG levels were negative. In June 24, slightly positive MOG, she was treated with immunomodulator. October 24, MOG titers were negative. In March 25, it is positive. In November 2025, her MOG titers were positive, and in June 2026, her NMO MOG panel was negative. So this is the course in the last 1 year. In April, right eye pain with blurring and sudden loss of vision. In November, left eye pain with loss of vision. And in January, she has a fluctuating vision loss, and her visual acuity in March is 20/20 in both eyes with the RAPD grade 2. That's all, ma'am. And these are the current guidelines for the treatment of acute symptoms of MOG. Should I go with it, ma'am?
You can present if the number of
Slides.
slides
Yeah.
if you have 3 to 4 minutes more.
Yeah, okay. So this is the MOG consortium's consensus from 2020. When the MOG antibody positive pediatric patient presents with the acute symptoms, so we first treat with IV methyl. Well, we should treat with IV methylprednisolone with the pulse dose regimen, 20 to 30 milligram per kg per day for 3 to 5 days, depending on the disease burden and response treatment. If there is no treatment, then we can go for IVIG, 1 to 2 gram per kg in the next 1 to 5 days. And if there is no improvement, then we can go for Plex plasmapheresis for up to 5 cycles. In a relapsed patient, when there is no response to treatment and there is a relapse to the situation, so we'll switch to immunomodulators like rituximab or IVIG. The combined rituximab and IVIG treatment can be given. The doses for immunomodulators, azathioprine can be given at 2 to 3 milligram per kg per day, daily basis. But before that, we have to do TPMT genotype. Uh, Mycophenolate mofetil, it's 600 to 1200 milligram per meter square per day, daily. It is oral dose. Rituximab, 375 milligram per meter square with 1 week interval. Immunoglobulins like IVIG, uh, that we have described, 2 gram per kg in next for 1 to 5 days. Prednisolone in a tapering doses. So takeaway points from this case. So the one disease teaches you all the types, all the pattern of MOG that manifest as flames, encephalitis, Adam-like illness, optic neuritis, and epilepsy at different points over years. So think flames early, as the flames was considered as a distinguished entity, but now it is considered as as a part of the mob. When there are relapses can look different at each time. It should be treated accordingly. Titers are a guide, not a gate. So the positive titers, antibody status fluctuated between the relapses, and the escalate therapy for relapsing courses. If there are relapses with the MOG antibody positivity, and acute attacks responding to high dose steroids and IVIG plasmapheresis, and rituximab MMF can be considered for the relapses. Early immunotherapy protects the vision and function, as optic neuritis uh, responds well to immunomodulation. So these are according to literature review. Morgat phenotype presents as isolated optic neuritis, flames, epilepsy or encephalitis, and Adam-like presentation. So this is the review article into 2020 from Seshi and et al. We suggest you of age, if in a pediatric population, optic neuritis and Adam present contributes same percentage. In adults, optic neuritis contributes more, followed by myelitis and Adam. In unilateral cortical flare, this is one article in from 2019. Unilateral cortical flare hyperintense lesions with the flames presented with the seizures. So the Ogawa has described the entity flames studied by Ogawa, and term is coined by Burtham. And these are the percentage of the symptoms. In 20 patients, 85% presented with the seizures, 70% with the headache, 65% with the fever, 55% with the cortical symptoms, and if there are more than two findings, where 95% patients. So this is one more study in from 2025 with Mogad with seizures in the children. It was studied in 125 children with MOGAD positivity, which was studied in a retrospective manner from 2019, July 2019 to 2020, 24 to 2019. Here, the MRI suggested the unilateral hyperintense lesions. These are the classical pattern of the flames. This is the pediatric MOGAT associated encephalitis review article from 2024, which was studied in the 235 patients, from which 14% were identified as encephalitis, and 31% were presented with the ADAM, and the most common presentation were encephalitis with the headache, seizures, and fever. So, following the graph, the relapse rate is more in optic neuritis and autoimmune encephalitis. Now, this is the chart. So, thank you.
Thank you, Dr. Jayashree. This was a wonderful presentation. It highlights the complex case of MOGAD, especially the relapsing, as 1/3 cases can become monophasic, but here the patient had recurrent episodes. Dr. Satish, do you have any points to add on and regarding the treatment aspect
Yes,
and the
ma'am. So
diagnostic?
this child is a clear indication of how varied MOGAD presentation. Initial presentation. Also, the treatment guidelines have changed quite a bit since the last in the last decade. Although IVMP and IVIG are considered the first line treatments, even now we are slowly moving away from steroids and going for early steroid sparing medications like MMF and azathioprine, mostly MMF in most of the centers. But here one the optic neuritis episodes have recovered very well on follow-up. Her vision was almost back to baseline, which again points towards MOGAD. And unlike in MS and NMO, where there can be a residual vision deficits and the recovery can be quite prolonged and poor as well. So
Okay.
one thing that has to be kept in mind even for us is even though we see a unilateral lesion in the cortex, don't think it might always be a infection related thing. Always think of MOGAD also, because early treatment can lead to good outcomes as well. And coming to second line medications, now we are seeing more and more frequent usage of rituximab. So the dose and schedules can vary slightly from center to center. Regarding one question which was asked in the chat, IVIG versus apheresis. Usually we go either with apheresis or an IVIG, but there are some centers which are doing combined IVIG and apheresis, but the whether how useful it is still not sure, because there are thought process that when you do a plasma exchange, you are sifting out the immunoglobulin as well. But
Yeah.
overall, yes, this child is like a classical example of how varied mock presentation can be. And if treated early, it can show good outcomes.
Okay. In this patient, for this optic neuritis, when it was not recovered, I think the question was meant like plasmapheresis after IVIG.
Yeah.
So you have not given combined therapy for this particular patient, no?
No, ma'am. I think first plasmapheresis
was
was done and then
uh,
IVIG was done.
IVIG. That was a doubt, I believe.
Yeah. But
Udani
some
sir,
centers do follow if the presentations are very severe. I have seen a few centers which follow IVIG along with plasmapheresis as well.
okay. Udani sir, your valuable comments, please, regarding the diagnosis of MOGAD and its treatment part, especially.
Yeah, thank you very much for this very interesting case. I think it illustrates that the initial, of course, you had a cortical encephalitis kind of picture with flames being the MRI signature, and that patient's had status, maybe developed a mesotemporal sclerosis secondary to that. And then goes into a repeated ADEM and optic neuritis kind of phenotype, relapses over many years. I think this shows us this is the first important thing that, like somebody's mentioned already, you get different types of, Dr. Chaudhary has mentioned, you get different types of pictures. So usually, patients who are young, like in this patient was, I think, 5 or 6 when she first got the first, like 7 years old, they have a much less aggressive kind of relapsing course. than those who present later on after the age of 9 or 10. So that's an unusual thing. Second thing which was interesting was that the MOG antibodies went up and down. Now, we do not really have the MOG titers in this case. And nowadays, we do MOG titers. And if your titers are more than 1 in 100, you're considered positive. Otherwise, weak positivity, etc., maybe, sometimes. But I think the clinical course and the number of times MOG has been positive, there's no doubt about the diagnosis in this
Yes.
case. The third thing, the MOG antibodies can become negative interim and then come up again. So that has been well described. The third thing is, what are the best treatment choices for MOG? And the problem is, up till now, recently, of course, I'll talk about the study a little later, but essentially, people who are giving different regimens and different experts who are giving different ideas. We also, I think Dr. Vishal Sondhi will tell us about MOG, the study which was done in India. But essentially, IVIG, in my experience, repeated IVIG injections seems to be the most beneficial prophylactic therapy to prevent relapses. Or long-term steroids. Long-term steroids obviously has its own problems, therefore it is not preferred. Mycophenolate and azathioprine are there, but they are not great in terms of percentage of response. And the problem is you have to wait for a long time before they become effective. And the rituximab has got mixed reviews. Some of this paper say it's helpful, some of them say it's not helpful. Just to bring you to a recent article, Meteoroid article, this was published in April 2026, randomized controlled trial, where they actually found in patients above the age of 12, satralizumab as a compared to placebo. So it was a definite improvement, the 70% or so reduction in the MOG attacks. So this is the first randomized controlled trial of MOG. Obviously, it's a very expensive drug and, may not be available very easily. That's all. Thank you.
Thank you, sir. And now, Dr. Vishal, do you have to share your experience? And
Thank you very much, and a wonderful case. A couple of things. First, I think the first important lesson is, which is also a paper which was published by Udani sir, that if you see demyelination occurring with concurrent fever, then you always start thinking of MOGAD straight away. Because usually we say there's a gap between fever, febrile illness, and the para-infectious or post-infectious demyelination setting in. But MOGAD, we have seen quite a lot of time comes along with fever. Second is a lot of MOGAD comes with CSF pleocytosis as well. So, which at times creates a confusion between ongoing infection or a demyelination. Third is, again, we found in our collective data that MOG has a fleeting kind of presentation. So the same kid, in this case, also started with encephalitis, later on went on to develop edema, optic neuritis. In between one of the MRIs also showed maybe partly NMOSD kind of a presentation with LETM, and so it keeps on moving from one phenotype to another clinical phenotype. Regarding the role of various maintenance immunotherapies, Udani sir has already brought out. What we also found was IVIG is the best in terms of preventing disability and in terms of preventing relapses. Steroids was equally as good, but definitely cheaper than IVIG. But again, the side effects make it difficult to carry on forever. And rituximab is better than giving nothing at all, but definitely it's not as good as IVIG or steroids. And lastly, if there have been certain papers which have highlighted that it is not that MOGAD doesn't have a permanent disability. If you follow them long enough, you will start seeing disability. What I found interesting in this case was there was a particular slide where they said that there was gliosis in the medial temporal lobe which has started setting in. So that is really interesting. That is it sequelae of MOGAD, which has happened for about 5-7 years, or is it something else? We don't know, but definitely if we follow up MOGAD long enough and if they keep on having relapses, definitely a permanent disability is likely to set in.
Thank you. As we have a few questions in the chat box, and the moderators or the panelists are free to type those answers. And if we have time in the end, we will discuss those questions. And now we will move on to the next case. So I invite Dr. Shubham Raj to present from resident from neurology resident from PGI Chandigarh to present his case. It's an
Good
interesting
evening,
case,
everyone.
double whammy of infection and inflammation.
Good evening, everyone. So I'll be presenting the case. So our index side, Miss K, 8 years girl from Korli, Punjab, was admitted to us in 20th of September till 19th of October. Received complaints of fever for 6 days, followed by ultrasensory for 4 days. Pre-morbidity, child was well, studied in class 5 with good scholastic performance. And on first day of illness, the child had fever, multiple spikes, which continued to around 5 to 6 days. The child had multiple spikes of fever with maximum temperature up to 103 degrees Fahrenheit, associated with chills and relieving on antibiotics. Followed by that, the child also had onset of headache, which was bifrontal, dull aching, gradually increasing in severity, and it was severe enough to hamper the sleep as well as the daily activity. And it was more in the morning. No postural variation was there, and there was no squint or diplopia. The child also had episodes of vomiting with no relief of headache. And on second day of illness, the child also started having multiple episodes of seizures. And the seizures were awake, unknown onset, bilateral rhythmic jerky movements with uprolling of eyebrows, and each episode lasted around 4 to 5 minutes. Followed by that, the child had onset of encephalopathy with initially reduced verbal output, followed by that increased lethargy and sleepiness, non-recognition of parents, as well as only intermittent eye opening of falling, which was gradually progressive, and it progressed over next 48 to 72 hours to only eye opening on painful stimulus and no verbal output even on pain, with loss of awareness and only sleep-wake cycle. So with these complaints, the child was taken to outside hospital on 4th day of illness, where anti-seizure medication and IV fluids were given. But in view of worsening encephalopathy, the child was referred to PGI and the child was admitted. There were no history of behavioral abnormalities, positive limb movements, no history suggestive of cranial deficits or any other movement disorders, neck stiffness, sensory abnormalities, or involvement of bowel or bladder. There is no history of URTI, loose stools, rash, joint pain, or swelling, or any photosensitivity or loss of hairs. No history suggestive of any autoimmunity in the child or in the family. When the child presented at trials, the airway was open but unstable in view of encephalopathy. The child had respiratory rate of 20 per minute, but efforts were poor. Auscultation was normal, saturation was normal, circulation-wise, the hemodynamics were normal, and the child had GCS of E2, B1, M4 with anisocoria. Final physiological categorization was primary brain dysfunction with level 1 resuscitation required. On examination, the child hemodynamical child was stable and the saturation was maintained. The child was intubated upfront in the trials and put on mechanical ventilator. Hemodynamics were normal. Anthropometry was preserved. On general physical examination, the head-to-toe examination didn't reveal any significant findings. Coming to neurological examination, the child was encephalopathic and was in unresponsive wakefulness syndrome. Cranial examination revealed pupils 3.5 millimeter, bilaterally sluggishly reactive to light, no fixation, and random eye movements were present. Dorsal eye was present, there was no facial deviation, and the uvula was in midline, and cup was also present. On examination, a motor system bulk was preserved, and generalized hypotonia was there. Reflexes were superficial, and deep reflexes were normal. And the child, however, the power would not be assessed in view of encephalopathy. There were bilateral sustained intermittent twisting of bilateral upper and lower limbs only in awake state, which was suggestive of generalized dystonia. There were no cerebellar or meningeal signs. The other systemic examination were normal. So coming to historical analysis, we had 8 years girl, previously well, developmentally appropriate with acute febrile encephalopathy with seizures. On further examination, the child was encephalopathic. There were features of raised ICP, generalized hypotonia, and extrapyramidal features without any other organ system involvement. So we had acute encephalitis syndrome with raised ICP with seizures with extrapyramidal features. So coming to possibilities, mainly two possibilities were kept: infectious and immune processes. So in infectious, systemic tropical infections like dengue, scrub, malaria was kept, and viral encephalitis like Japanese encephalitis, herpes simplex, Epstein-Barr was kept. Another possibility of bacterial mycoplasma was also kept. Coming to immune processes, demyelination, autoimmune encephalitis, and infection-triggered encephalitis syndromes were kept. So coming to ER and ICU course in our index case, the respiratory failure, for respiratory failure, the child was mechanically ventilated, and the child required ICU stay of around 12 days, out of which around 8 to 9 days of mechanical ventilation was done, and followed by that, the child was extubated to BiPAP. For primary illness, infective etiology was considered, and the child was started upfront on ceftriaxone and azithromycin and acyclovir. The imaging done was revealing cortical and subcortical involvement, along with significant involvement of bilateral basal ganglia and thalamus, with striatal involvement, as well as obliteration of sulcal spaces, revealing diffuse cortical edema. In frontal lobes, there was evidence of diffuse bilateral subcortical white matter diffusion restriction. So, possibility of immediate CNS damage was also kept in view of pleocytosis and elevated protein, increased CSF IL-6 and increased serum IL-6. So, injection methylprednisolone was administered for 5 days, followed by IVIG at 2 gram per kg, and followed by tapering oral steroids. For the child also developed healthcare associated infections on 4th day of illness, following which for which culture sensitivity appropriate IV antibiotics were administered. The child had initially seizures, for which midage infusion requiring up to 16 mics per kg per minute was administered, followed by anti-seizure medications, phenytoin, levetiracetam, and clobazam. Following that, the seizures were passive. However, there was recurrence of seizures on 9th day of illness, requiring optimization of anti-seizure medications. Following that, on 12th day of admission, the child was shifted to neurology ward. Following the shifting, the child again had a recurrence of respiratory worsening, requiring reintubation, and subsequently the child was extubated on 20th day of admission, and the respiratory support was gradually tapered by day 25 of hospital stay. For primary illness, oral steroids were tapered and stopped. However, JE serology came out to be IgM positive for Japanese encephalitis. Subsequently, rehabilitation was continued. For seizures, the seizures recurrence did not occur after that, and the anti-seizure medications were continued. The child was put on anti-dystonic measures, following which dystonias were controlled. The child was discharged on 30th day of admission. The child had intermittent dystonia at time of discharge. GMFCS was 5 and modified ranking scale was 5. These were the investigations. In this, we can see at the time of admission, the child had mild transaminitis, and which was an improving trend. 2 times CSF was done. Both of them showed pilocytosis with lymphocytic predominance and elevated protein. Gram-stain and culture was sterile. HSP and PCR was negative. CSF IL-6 was elevated, around 577 picogram per ml. Serum IL-6 was also elevated, 1095 picogram per ml. J serology IgM positive. Otherwise, MOG and ecoprin-4 was negative. CSF autoimmune panel was negative, and dengue and scrub serology were negative. So final diagnosis kept was 8 years girl with acute encephalitis syndrome with features of raised ICP, biphasic seizures, extrapyramidal seizures in form of generalized dystonia and Parkinsonism, transaminitis, CSF pleocytosis, raised protein, JE serology positive, cytokine storm with bilateral basal ganglion thalamus involvement with subcortical white matter involvement along with diffusion restriction. So final diagnosis kept was Japanese encephalitis with superimposed cytokine storm, coexistence of JE and infection-triggered encephalopathy syndrome spectrum. So at follow-up at 2 weeks, the child was bedridden with MRS of 5, GMFCS 5. Comprehension was relatively preserved, but no verbal output. Eye contact was present, and the child was able to fixate and follow. Cognition was improved. However, the child had Parkinsonism in form of rigidity as well as bradykinesia. The child had very much reduced frequency of eyelid blinking. Following which, the child was given syndopa, levodopa, carbidopa trial, and the intermittent dystonia of left upper limb was also there, for which anti-dystonic measures were optimized. ASMs were tapered and stopped. follow up at 3 months, the child responded quite well to Syndopa trial. Following with the child became completely ambulatory, and the child was attending school. The child had normal communication and was able to do age-appropriate activities of daily living. MRS was 1 and GMFCS was 1. However, the C continued to have intermittent dystonia of left upper limb with improved Parkinsonism. So optimization of drug doses were done, ASM tapering was started, and the ASMs were stopped. At 6 months follow-up, the child was completely ambulatory, attending school, normal communication, able to do age-appropriate activities of daily living, no dystonia, and levodopa and carbidopa were continued. Follow-up imaging showed resolution of signal intensities with sequelae in form of microhemorrhages, resolution of subcortical white matter diffusion restriction. This is the video at follow-up. So these are the images. At admission, we had subcortical white matter diffusion restriction, and at 6 months MRI, the follow-up MRI shows resolution of this diffusion restriction. So these were the images at 6 months follow-up. In this, we can see resolution of the altered signal intensities with some microhemorrhages and gliosis in bilateral thalamus, midbrain, as well as resolution of altered signal intensity and diffusion restriction. So coming to the diagnosis, JE and cytokine storm, query of infection triggered encephalopathy syndrome. So the child had acute febrile illness, which was followed by rapid onset altered sensorium by physics seizures, and MRI had bilateral thalamic and substantia nigra T2 flare hyperintensities, which are classic of JE pattern of MRI imaging. JE serology was also positive, and however, elevated serum IL-6 and CSF IL-6 along with bifrontal diffusion restriction was evidence of systemic cytokine storm. See, even in all cases of JE, there can be elevated CSF IL-6. However, the range is around 200 to 300. But in our index case, it was above 500, around 600 picogram per ml. So confirmed JE with primary CNS infection with superimposed cytokine storm was kept. Coming to infection triggered encephalopathy syndrome, it is a clinical radiological diagnosis which requires infection, clinical encephalopathy, along with classical neuroradiological features and exclusion of other causes. So traditionally, primary CNS infection is considered as an exclusion criteria for ITS. However, this index case, their infection was in CNS. So the traditional boundaries between this is the consensus guidelines required primary CNS infection as an exclusion criteria. However, neurotropic viruses directly invade CNS and can have similar clinical course as well as imaging findings, which can be seen with JE, as well as we also are aware of the dengue as a diagnosis. So even CNS infections can trigger massive neuroinflammatory cytokine release. So elevated CM IL-6 as well as CSF IL-6 in confirmed case of JE or dengue can indicate superimposed cytokine storm, which is the hallmark of ITS despite a primary CNS infection. So pathomechanism is the JE entry is there, microglial activation is there, and which can lead to cytokine storm, which disrupts blood-brain barrier and lead to encephalopathy. So the question arises: should we treat both, or should we just go along with the rehabilitation as in cases of JE? So coexistence of JE and ITS, we have seen IL-6 as I've already discussed. IL-6 levels in JE patients tend to rise up to 100 to 200, but our index case showed very high levels of IL-6. So possibility of coexistence of JE and ITS spectrum pathology was kept. So in this index case, we went ahead with immunomodulation with methylprednisolone and IVIG, along with symptomatic and supportive management. So the rationale was immunotherapy directly targets the ITS like cytokine storm component coexisting with JE primary CNS infection. So key messages I would like to discuss are clinically for severe CNS infections with biphasic seizure and systemic ischemia with transaminitis, elevated serum and CSF IL-6 possibility of associated cytokine storm should be considered, and decision of immunomodulation should be case-to-case basis and based on IL-6 levels and clinical radiological features, even in cases with primary CNS infection. Thank you.
Thank you, Dr. Shubham. This is very interesting case. As the title suggests, it's a double whammy with Japanese encephalitis positive as well as with the ITES. So, Dr. Priyanka, do you want to add on to the particular case with regard to your experience and management aspects?
Thank you, Dr. Soumya. Very good evening to all. This was an unusual case for us also. So the child had already received immunomodulation before coming to the ward. So in ER and ICU, child had already received immunomodulation, and then because of the thalamic and brainstem lesions, we suspected Japanese encephalitis, and the serology came out to be positive. So as the child was improving, we did not give tocilizumab. We just like gave methylprednisolone and IVIG, and there was like dramatic improvement in context of seizures, although child had persistent encephalopathy, which also subsequently gradually improved. So I think although ITS per se is considered only in cases of peripheral infection instead of CNS infection per se are exclusion criteria for ITES, but infection and inflammation can of course coexist, and decision has to be made on case to case basis. Thank you.
Thank you. So we also had a case of Anik who had a hepatitis B positivity, suspicious of SLE. So we also persisted with steroids and IVIG alone, but the child made a good improvement, remarkable. So Udani sir, your experience with regard to any CNS infections or ITS as such, and the management with tocilizumab. I think he has logged out for some connectivity problem. Dr. Vishal?
Hi, Dr. Shubham and Priyanka, fantastic case. Honestly, as you have already brought out, the moment we start thinking of ITES or ANIC, we try to rule out things like JE, and if it is JE positive, we say it's unlikely to be ANIC. But this case kind of challenges those boundaries. And definitely in ANIC, we end up using methylpred IVIG, and in fact, early tocilizumab also we have used in a lot of cases and seen good results. But whether when to decide to use it in conditions like JE, I don't know. I don't have an answer for that. But yes, on a case-to-case basis now, I'll be forced to think that okay, let's look at the inflammatory markers and move towards using all these methylpred or IL-6 blockers. But very interesting, very interesting.
Thank you.
So we have a few questions in the chat box. In future, regarding this particular case, in future, can child have any chance of developing PD, Parkinson's disease? So I think the Parkinson's disease is a degenerative process, and this usually occurs after the age of 50 years. So this child may develop Parkinsonism or dystonia later on, secondary to the thalamic involvement or the fronto-basal ganglia thalamic circuits and all. Then another question, after recovery, child had loss of associated movements while walking. Is there anything, what was the prognosis? After recovery, child had loss of associated movements while walking. So the question, was there any involuntary movements after the recovery?
After recovery, actually, the child was able to ambulate, and there were only intermittent dystonias of left upper limb that was persisting. Otherwise, the child was ambulatory.
So remarkable, at least good recovery was there for the patient. And regarding this particular case, these were the few questions. And regarding the earlier case, case 1, we have a few pending questions are there. One is with regard to the use of tocilizumab. So Dr. Satish or anyone in the expert panel could answer that with regard to the experience with tocilizumab and MOGAD. Dr. Vishal?
Overall, tocilizumab, we generally don't use much in MOGAD, but recently it's been suggested as a third-line medication with severe presentations and all. As of now, I have not seen any mock cases being treated with tocilizumab. Mostly we use it mostly for ITES and all, but recently we have seen a few case reports and published literature. Even there is a
Okay.
recent article of a French consortium which is suggesting tocilizumab as a potential third line for severe presentation.
Okay. And another question, is there any contraindications for giving steroids in active viral infection, mostly in CNS infections? Dr. Shubham or Dr. Priyanka or Dr. Vishal could.
For me, I can think of indications of giving immunomodulation. Even in cases like dengue and NNC, there is direct infection of CNS as well as there is cytokine storm. So I think this should be based on case-to-case basis, and
Yeah.
I think more of review of articles, literature is required, and further research is required for this answer. I
Yes,
think it should
right.
not be based on upfront like all cases of viral infection of CNS should receive immunomodulation, but based on case-to-case.
Is rightly answered. So during infection, CNS infection could be direct brain invasion or could be because of this infection triggered encephalopathy, cytokine storm, or a post-infectious immunological phenomena that is happening. So we have to find out what is underlying pathobiological mechanism and then treat the patient. That's rightly said. Any comments from Shafali madam or Mini madam regarding these cases, and do you want to add on to your experience?
Soumya, wonderful cases, wonderfully presented, and I
Yes.
think practically discussion is holistic and complete. Yeah.
Okay. I think almost all the questions have been in the chat box has been answered. So we have finished well ahead of time. So thanks to the presenters and the moderators. So any concluding remarks from madam or Mini madam?
And you want to say something?
Satish and Priyanka. Yeah.
Yes, you are audible, madam.
Uh,
So I think madam is not audible. I think it was a very wonderful session which has happened, and two very difficult cases to manage. One, recurrent episodes of MOGAD, and other is coexistence of both the infection as well as inflammation, and rightly managed, and the patients have both recovered very well. And this leaves a lot of discussion in these difficult cases, and still guidelines needs to evolve. So we will have again discussions later on with regard to these cases. Wonderfully presented, and thank you, the presenters, Dr. Jayashree, as well as Dr. Shubham, and the moderators, Dr. Priyanka, as well as Satish, and the expert panels, Dr. Udani sir, as well as Dr. Vishal. And thank you all the participants for attending this wonderful session. And thank you, Shafali madam and Mini madam. So we'll wind up the session now.
Thank you.
So
Thank
have
you.
a good dinner and good night.
Thank you.
Thank you.